Oh, we're being recorded. Great. Yeah, I'm very pleased to introduce Moritz Gerstung, who is from DKFZ, which I can't say the expansion of, but it's a cancer institute in Heidelberg, but also with EMBL-EBI, and he's going to talk to us about learning disease risks with AI.
Thanks, George, for the kind invitation. I'm very happy to be here and present some of the work that my group has been doing over the past couple of years, with particular focus on a recent model that uses AI to predict multi-disease progression. Is that correct in the room? Shall I use?
Okay. So it's okay.
That's okay, good. Since it's going to be a bit longer seminar, I thought I'd give you an overview, give you a short background on cancer risk, which is really how I got into it, because my main occupation was to study cancer and a variety of data science problems, from diagnostic questions to risk prediction. And this is how effectively this work came about. Then a specific application of training risk models using a large national registry data sets, and then Delphi, a recent generative AI model that goes beyond just the scope of predicting the risk of different cancer types. I would also think that please feel free to interrupt me, ask questions whenever something is unclear, because one of the big challenges of these AI models is that the machine learning community uses an entirely different vocabulary compared to statisticians. Even for the very same thing, they call it the cross-entropy loss, but then in fact this is just a normal likelihood of a multinomial classification model, and so on. So I can see how this can become confusing at times. So please raise your hands, and we'll be much more happy just to go through half of the slides only and make sure that you've been able to ask all the questions, and then just power through to the end and everyone is asleep. Okay, so just some basic statistics on cancer, which probably many of you know already. So the lifetime risk of cancer, sadly, is around 50%, meaning that every second person in the room is likely to receive the diagnosis at one point in their lifetime. And as you can see from the age incidence curves on the right, actually this risk really accumulates in the last third of our lifespan. So the majority of diagnoses occur after the age of 60. And this already tells us a lot about the natural history of the disease, because it is likely to reflect lifelong exposures leading to development of that disease. And one really iconic chart I find that summarizes much of it is this one, which just compares the number of cigarettes sold and then the cancer incidence. So one sees that basically the two curves have an almost identical shape, but the incidence in fact just lags by around 20 years. So that's one of the big problems of cancer, is that there's quite a long latency between the actual exposure and the onset of the disease, because it starts with introducing mutations in a single cell that is unlucky enough to have the right or wrong malignant combination of alterations, then to proliferate more, and that sets off a bit of an avalanche, but it takes a long time. So what we're seeing at the end of life is, in fact, therefore, the consequence of what we have been exposing ourselves advertently or inadvertently in the decades before. But that, of course, then means that then could we identify potentially certain cues in our behavioral, but also other data that already points towards exposures or certain risk factors, then in order to predict who is at a greater risk of developing or receiving a tumor diagnosis as they are already developing cancer without them realizing it. So we really need to look into the first half of life in order to make then an assessment for the later years. And it is, of course, especially important because cancer risk screening is really a challenge to balance risk, the risk of over-diagnosis, because no test is perfect, because since one has to, even though the incidence is 50% across all cancers across the entire lifetime, in a given year for a given cancer type, actually, it is more on the order of 1 in 1,000. So for breast cancer, this has been documented quite a bit. There are around 8 out of 1,000 women which are eligible for screening will have a breast tumor. So the vast majority will not have a cancer. And since the current mammography tests also produce certain rate of false positives, given the very low frequency of true positives, really the positive predictive value is not that high. One has, in fact, quite a high number of false positive initial diagnosis. It's also clear that the test is only effective after a certain age, for example, when there are those 8 cases to be discovered. It would not make a lot of sense to apply it already at the age of 30 without any additional indication, because that would mean then that the false positives would greatly outweigh than the true positives. So since this is about searching the needle in the haystack and the problems that can come also from false positive diagnosis requiring additional tests causing discomfort and in the worst case even over treatment, it would be ideal if I could further stratify the population in a subset which should already enter a screening program at perhaps an earlier stage or at a greater frequency, and others who would not have to go through as many investigations. So that's the basic idea why cancer risk modeling is, in our view, so important. And this might even become more relevant as also no new blood-based tests are being developed. For example, searching for tumor DNA fragments in blood. This might hold some great promise, not only to detect those tumors for which we can access tissue or image it, but also those which are deeply buried in our bodies, such, for example, pancreatic cancers or others, for which currently there are no screening programs. So one will also have to think probably outside of the scope of only breast cancer or other tumors for which tissue is easily accessible. So that's the background overall. And then our question was, does information from a person's health record provide clues about future cancer risks? So if we had effectively laid out all the results from our previous doctor's visits, say up to the age of 40, could there already be an indication for some individuals? Yes, perhaps this is someone who is already at a risk of a person who is, say, 50 and thus just reaching eligibility to enter a screening program. So it's not so much about discovering new risk factors. The big risk factors for cancer, they are all known. It is essentially tobacco smoking for a variety of cancers, predominantly lung tumors. It's also alcohol consumption, UV light exposure for skin, and then obesity and also lack of physical exercise. Right? But it is more about the small things, right? Can we piece together many of these more subtle clues that might exist, which can also be already associated with certain behavioral patterns? So it's not about identifying causal events, but rather can we piece information together for a more accurate prediction? So where can we in fact get information on a large scale that would be needed in order to learn such models? And here the Scandinavian countries, and especially Denmark, are really a gold mine, as you will probably also be aware, because they have a long history of national registries which gather data of the entire population through an implicit consent model. This is able to be accessed for research for accredited researchers. And so these different registries can be linked to each other through the social security numbers. For example, one can link the Danish National Patient Registry, which contains information from more than 60 million hospital visits of the entire population, covering more than 193 million life years and 90 million different diagnoses coded at ICD-10 with, for example, through the central person registry, we can link, for example, family cases to each other, which is extremely valuable as well.
Does that, what proportion of the overall population does that 6.73?
So that's, I think, at least 95%. Yes, so only a tiny fraction of individuals is opting out, and most of these are due to glitches. So it's very much cross-sectional. So, and thankfully, we had a very successful collaboration with Søren Brunak in Copenhagen, also Lars Mortensen. He's at the Danish Statistics Institute, who has basically provided the access to the data, which resided in Denmark in a secure computing environment. And then we could access that either by visiting or also through remote means in a secure way. Now, if you want to learn just very traditional risk models, because the simple thing would be, here is the set of all the data points, and we want to learn a cancer risk model. An obvious choice would be a Cox proportional hazards model. But just thinking about the volume of data, you just can't just open up an R section and put it all in, because we have 6.7 million rows, or even more if it's encoded in a time dependent fashion, and we have thousands of variables we check. You can see it's still just in terms of the n being millions and then the p being thousands, it is still a statistically sound dimensionality, right? We have enough data to train out some models that recognize so many effects. It's mostly a practical problem. And so what a student of mine, Alexander, has done was he has effectively repurposed some of the computing frameworks which are being used for training really those gigantic AI models. PyTorch is one, in order to train then standard statistical models on these data sets. So, and what these models do is in fact quite simple. So you specify the mathematical dependency, so response y is a function of the data x and parameters, and this can also be a nested definition. And what these models do effectively is they are a giant chain rule machine and evaluate the gradients for you. So you don't have to sit down and calculate how could I basically come up with a numerical solution. It just says, okay, as long as we know the gradients, we can then do an iterative optimization, right? So it's quite easy to use in that way. There are also some extensions that already provide the right statistical functions and likelihood terms, because that's ultimately what you want to optimize. And then there's one little problem, is that still, even with those, you can calculate then the gradients for 1,000 parameters of your model, or even millions, as in the, or billions, as in the current AI models. But there's one problem: you still can't load all the data rows into your memory yet. So the common trick there is to split the data into smaller batches and just do an optimization step with the model or the optimizer, just seeing a subset of rows effectively. One needs to do a little bit of likelihood reweighting, because then since as the number of data point changes in this optimization step, otherwise the models can be a bit biased. But this is also something that you can figure out analytically. And this is what Alex has described in this method, which we published in the Annals of Applied Statistics last 2 years ago. So very basically really just sound proper statistics meeting machine learning here. And then we applied this to the Danish registry data sets in order to learn cancer risk models. And that was published last year. So the information came from the sources which I mentioned already for the 6.7 million individuals. We extracted on 400,000, 440,000 cancer cases, 20 major cancer types. Used the existing ICD coding, which comprised more than 1,300 distinct codes and contained 90 million diagnoses. We also calculated through matching persons through the central person registry to their relatives. We calculated indicators of family cases using different legal degrees of relatedness, and also included basic lifestyle information that was available for a subset of individuals from like a major hospital in Copenhagen, which contained full text medical records. So our collaborators have been working with this, and for text mining, we're also able to extract information on age, height, because surprisingly, those simple things, they are not part of the registry. So and it's something I faces, I think, quite often. And this is, of course, we didn't want to go without it because this can be very informative for the major risk factors such as smoking or alcohol consumption. But the truth is, right, that these are surprisingly then hard to collect, to quantify, and also to store. But we did our best to also include this.
Did you have like timestamps for those? Right, so you would include time in that as well?
Yes, so for each of the diagnoses, we knew the respective date, and then the Cox proportional hazards model was effectively using the time-dependent covariates. So overall, the models are very well calibrated, as you can see from the calibration curves. So that speaks to them being like statistically well crafted. We also found that those richer models, they outperform, for example, the Q cancer risk model collection, which is not too surprising because they use much more data than just the select variables that go into those. You can also gauge from the margin of improvement, which is around 5 to 10 in some cases, more percent of AUC. That's, well, it may for many purposes be sufficient just to work with a simple model that just based on basic parameters. But still, overall, we saw an improvement. And importantly, this was a model that was trained in Denmark and evaluated on the UK Biobank. So it also shows that it generalizes very well between countries. So the ICD-10 coding really seems to be, at least at the granularity of the top levels, it is a bit of a hierarchical scheme. You can go to very fine-grained definition at the scale of 1,000 different diagnoses. It seems to be quite universally applicable between at least Western European countries. So that was all very reassuring. And if we looked at then the number of coefficients, it is in fact the case that now splitting those into like disease history and a set of coefficients that have a hazard ratio greater than 10%, so a small effect size, but many coefficients around 30, the median across the different cancer types. A lot of the previous diagnosis associated with mortality, many with lung cancer, and then it's a bit tailing off. The set of predictors come from a quite broad range of different diseases across the entire basically catalog of ICD chapters. So the taxonomy is grouped into different diseases. So that I think speaks also to those associations, not necessarily being prodromes of neoplasms, but rather reflections of other exposures or lifestyle patterns that then manifest, for example, in diseases that can be used then as a proxy effectively of establishing someone's cancer risk. So this is, I think, how one thinks about it. But it is, it can be useful to piece this information together, coming from many small effects. The family history was also quite a large contributor, typically around between 5 to 10 of the 80 different indicators we had. So we say cancer among a relative of first degree, cancer among relatives of second degree and third degree. So these were 3 indications. But also there were quite a number of associations, and also not always for the same cancer type, but it could also be related and seemingly unrelated ones. So probably reflecting, again, a combination of underlying genetics, but also shared behavioral patterns. Like in a family that is more likely that there are smokers, for example, then of course you see then the clustering of smoking associated cancers among them. It could go many ways, also taller families or bigger ones that then you see clustering. So this is therefore also from a purely prognostic or predictive point of view can still be useful information. And then basic health factors, of course, also have an influence. Yeah, so there was a lot to learn in these data, and I would invite you to just read the paper in much more detail, explore what those associations are, but it really got us demonstrated the value of this national registry level information in predicting cancer risk. And now comes the point where I changed gear a little bit, because what we used was we took 1,300 ICD-10 codes to predict a subset of 20 selected ICD-10 codes for cancers only. So we were always wondering at that time, in principle, we could just train another 1,280 such models for each of the other ICD diagnoses. But of course, that would be a massive effort, and we could have kept probably like 50 PhD students busy, and would have sorted out my career just for giving this out. But maybe they also thought, oh, maybe this is really not worth the effort really to go through this all. And then around, what was it, a bit more than 2 years ago, when ChatGPT just stormed into the scene, of course impressed how powerful this was as a chatbot and language model. I imagine you have also been there yourself. But we've been thinking about it, how the models, how do they really work? And in fact, what they do is they build sentences effectively letter by letter or word by word as a sequence. And it's quite amazing that simply due to their complexity, they can they learn not only to be grammatically correct or that across languages, but even then correct in terms of the content with exceptions, of course, but at least in the relative context, they can be conversational and indistinguishable from a human. So, but it's exclusively through learning effectively the dependencies of the order of these words or word fragments, or as the machine learning community calls them, tokens. So basically, they give an indicator to each of those words and then model the sequence of it. Well, it's a sequence of words, right? What do we face when we model disease progression? It's effectively then a sequence of diagnosis, right? And if simply just a different vocabulary, and this is predefined if we were to use then, say, the ICD-10 catalog. Much simpler, in fact, than actual language, with many more tokens. I think the current LLMs, they use a vocabulary that contains around 1 million or so different tokens. Right? So here we only have 1,000. There's, however, one difference, right? In a sentence, there is an incremental order, but here we see this as a progression throughout continuous time or age. So this is something that we need effectively the model to be aware of, because we want to be able to say, well, this is the rate at which a certain disease occurs based on the history until this point. So say the incidence of 13 cases per 1,000 per year. This is what we want the model to calculate, rather than just the chance of the next word is X. So we had, if we were to model it this way, even though there is a strong analogy in terms of the basic problem, it has to be time dependent. And how can we extend an existing LLM or large language model architecture to be aware of time? So that was our challenge. And so this diagram shows a standard architecture called GPT, which is in ChatGPT in a dramatically scaled up form, but the essential building block is the same. So in red are our modifications. I will go through them and explain the rationale. But basically is the data goes in at the bottom, and then is this repeated calculation structure, which is called the attention block. So what happens is each word or token in the machine learning terminology, and so there's an indicator effectively, then thousands of indicators, they are converted into what the machine learning people call embeddings. So basically this is a representation that has a certain dimensionality that one can choose. So current LLMs, they use a dimensionality of several thousand. So basically you map each of your inputs somewhere into this n-dimensional embedding space. And so then there is an entire sequence of such inputs in the n dimensions. And then this structure is essentially, just in the most simple terms, think about of a repeated regression that basically occurs in both the dimension of time and along the dimensions or positions and the dimension of the embeddings to massage out the information, which then eventually, after n iterations, goes into a multivariate normal, a multinomial classification step that calculates the probabilities of the next word. So, and machine learning people just rather say it's multinomial probability, call it softmax, and so that's exactly the confusion that occurs there. Yeah, so that's it. You can choose how many dimensions you use for the calculations to happen. You can also choose your the number of repeated calculation steps, which introduce then an extent of nonlinearity in it. And there are this so-called attention mechanism is such that the model at any point in time, even though it sees this time series for each consecutive prediction step, it only accounts for effectively the data points on the left. So it does not use information from the future. And the machine learning people call it COL. Of course, as epidemiologists, one needs to be very, very cautious about this word. But it is essentially just effectively the temporal ordering.
And in terms of the iteration, the NX, is there other diminishing returns from doing more and more of them, or?
Yes.
Yeah.
Yeah, so it becomes more costly. Every of these iterations comes in also with a certain number of parameters. And overall, what people have shown is there are some so-called scaling laws, depending on how accurate the model gets in terms of the what they call a probability, likelihood, we should say. It is the total number of parameters relative to the number of data points that determines how many you choose. Roughly, you choose the best performing models, typically, so you get better. And when your number of parameters is about 1/20th of the number of data points, they're optimal. And you can spread them either in the number of dimensions or the number of steps. It's a bit exchangeable, surprisingly. That's optimal. And after that, then it goes down again because essentially the models have much variance. Okay, so that's for the questions.
So how do you implement the age encoding bit? So when you represent.
Yes, I'll get to this. Okay. Yes. So perhaps now let's start about our amendments. So we need to, first of all, make the model also aware of time. And now doing a slight excursion, it's almost like waiting time models 101. But as a refresher, so if we model then stochastic processes or waiting time processes, then typical choice would be if we define the probability that an event occurs in the time interval between t and dt. Let's call this lambda as the intensity or rate function. And then we know that then the probability density has effectively this exponential structure. And if we have now, say for the sake of simplicity, say lambda is constant for the time being, but now we have imagine we have a situation where we have multiple competing events all being exponentially distributed. There's some interesting and very basic mathematical dependencies. So now we have, say, 5 different things that are competing with another, and we want to measure what is the next thing that's going to happen out of the 5. Each of the 5 have a different rate. Well, so the time to the next event will be the minimum of the 5 waiting times. And what we can show is then that the time to the next event, irrespective of what it is also exponentially distributed, and the rate or intensity is just the sum of the lambdas which are competing. So that's a basic mathematical fact. So basically, you stay within the exponential waiting time process. That is good. And if we're interested in then which of the next events are actually occurring, that is a fact then a multivariate logistic model where the probability is just effectively lambda divided by the sum of all lambdas. So that's then the probability that event type I occurs. And here, the fact that basically which events can be is the next one can be parameterized in terms of just the relative ratio of the individual intensity function, and then allows us then to provide it back to the standard classification task, because that's that problem, which is the next event. This is what the models are already solving via a calculation that parameterizes the logits of the multivariate logistic models. Since we now have effectively that analogy between the calculated logits for the classification part, which should be the next word, and we just need to exponentiate it in order to get this into a rate or intensity. We actually can use very much the same underlying structure by solving the dual objective of finding out how long does it take and what is going to happen. So what we then need to do is, in addition to this part, the normal one, which is the multi-nominal logistic part for the next token, we just use then the same underlying logits that measure then effectively the probabilities and attach then also the additional objective, the likelihood of through an exponential waiting time distribution, but just summing up all the exponentiated logits to model the observed times to the next events. And that's beautiful because we have effectively a coherent framework that now solves the dual objective. And it's also interesting because the standard classification bit effectively is degenerate value 1 because all the probabilities need to sum to 1. But with this additional task that then needs to calculate the absolute rate of the event, it then also becomes fully identifiable. Right? So each of the logs has an actual meaning. It's not just that they are all defined up to basically the normalization constant. So we don't need to change much, just add this additional likelihood term here, where we then, as an additional data point, give the time to the next event. But then we also need to change the input. Or do you have questions so far? All clear, at least at an emotional level. So this is one of you and Bernie's terms, emotional understanding.
Yeah.
I hope you have this provides an an intuition. And interestingly enough, there have been many people who have been trying to use these models for modeling effectively complex time series. And they all effectively, in my view, failed, or at least were not able to come up with good models, because rather than just using this analogy here between waiting time processes and the exponential rate and then the classification, effectively said, oh, we use the effectively like a linear regression equivalent of then the time to the next event, or a log transformed one, which kind of gives you the right trend, but it never really then works out quantitatively and becomes calibrated. So I think this was really the key to what I will show later, the performance and accuracy of this type of modeling. So we also need to effectively provide the model with more information, because we don't only wanted to say, well, based on the discrete sequence of events, make predictions about the rates, but then also provide when the events to this point have occurred. So what we effectively include here is additional information. We also, I should say, in terms of the exponential weighting, we assume that basically the rates are actually piecewise or constant over a certain period of time. We also add additional information to allow the model effectively to progress through time by having an extra indicator variable which you randomly add to the data at a rate of once every 5 years, because otherwise the model is not, it only updates its prediction whenever a new data point is recorded. And if there is an individual who has basically a very sparse health history throughout the first, say, 30 or 40 years, as happens frequently, then the model would otherwise be challenged with the task of, at birth, it has to learn all the things that can happen over 40 years. And of course, well, in the first 10 years, maybe the thing you're most worried about is perhaps chickenpox. Whereas then when you're in your 20s and female, it's about giving birth as a diagnosis and so on. But these are clearly not competing at the same time. And therefore the model needs to advance. And this is why we use these additional uninformative padding tokens. And providing that, but also then we provide effectively the times at when diseases are occurring. And for this, we use what machine learning people use called encoding. Effectively, it does the same thing as actually mapping the disease indicators into this multidimensional embedding, but now we have quantitative information. So you need to think about a certain set of basis functions in order to parameterize it. And the typical choices effectively use then cosine basis function that effectively span this multidimensional space, which allow you then to map also continuous information, in this case, then the times or ages at which the quantitative age information is recorded into this embedding. It's very naive, and basically how to make sense of this information, it all occurs then at the subsequent iterative calculation steps. This is where then the model somewhat really magically can figure it out which dimension of this embedding to use in order to calculate then the next steps. So this is, and for that it needs to see lots and lots of data.
Sorry if I got lost, but the way in which the model is to be applied to the testing data, if you have an age range that you were targeting, or is it trying to be generic? Like it could be applied at birth, but there'll be very few indicator variables at birth. But if it was applied at middle age, then a lot of events have happened. Or, do you know what I mean?
Yeah.
Like,
so we have applied it over the entire age range up to the age of 80, because our main training source was the UK Biobank. And for this, then people are right now typically between the age of 70, and few are older than 80. But since for those we had effectively the data throughout their entire lifespan, and I'll get back to it, it was variable quality in different periods. And something one has to be very, very cautious about. But that allows it basically, it evaluates all the different steps throughout someone's life in order to effectively calculate then the subsequent rates of respectively always to the next event.
Yeah, okay. So like it won't assume it's being trained on the assumption that it's censored knowledge about the future
Yes.
in order to like predict from a particular time point to the future.
Yeah, it is very much like effectively at every point it has in a way the right censoring process. It knows kind of who is at risk of developing and the next thing. So you could think about it as like a massive and super complex competing risk model. And this backbone actually allows you to model the mutual dependencies among the different outcomes. So this all sounds perhaps plausible or maybe not. So the proof of the pudding is in the eating. And I should say, it really started as a bit of a toy project. So it was, yeah, maybe we could model all disease, but it also sounds a little mad. So let's see what comes out. Oh, maybe there's one additional step. I mentioned that because it takes inputs, the entirety of or a sequence of events, but it learns from every incremental step in between. But in order to learn from the steps, it only should access what happened before. It has basically this internal restriction only to access information. In text, it is what is on the left. In continuous time, it is basically what happened strictly before. And yes, don't get upset about this causal term, which is really just the machine learning sprech here. Right? It's not causal in the true sense. Okay, so proof of the pudding in the eating. So we trained it on the UK Biobank, but by our collaborators, we also have the opportunity to evaluate it on Danish data. We couldn't go the other way around because it was an iterative process of developing the model, and the access in Denmark is, even though it contains more data, it's a bit more clunky than the UK Biobank, which at least until last year you could still download and work on your local environment. So we split it into cross-sectionally into a training and a validation set from the same time period, but we also left out the last 2 years for then a longitudinal validation, so which we never really used for effectively further evaluation. Because one needs to be cautious in iteratively building models that one does not fall victim of effectively doing things and overfitting unintentionally. Good. So here are some of the model calculations. I'll walk you through it, what it shows. So this panel of diagrams shows different diagnoses, 8 selected one, including death, as a function of age. And on the y-axis is the model's calculated rate. And every point is 1 point for a given individual where the model makes a prediction. So basically, the predictions are occurring whenever a data input was provided. This can be a disease that is recorded or some of these uninformative padding tools. For reference, we included the step lines, which are just the crude age incidences for the 2 sexes. And what we would expect is that the model, at least as a baseline, somewhere makes predictions which are following the age incidence trends, right? And we would hope that, as you can also appreciate, that the age incidence, because it's extremely varied. For most diseases, it goes up as we age, often exponentially. Others, such as chickenpox, there's a clear peak when you're young, and then because young is really up again when you have kids yourself. There are also differences between the sexes, and this is something that a model should learn. So seeing the points that actually then follow this baseline trend is like a minimal requirement for well-calibrated prediction. And you can see it does that. And then I've done one thing. I've colored the dots dependent on, you can see some light colors. I hope you can also appreciate it from the back, and the darker color. So the dark colors are time points where the next event was in fact the one as stated on the top. So what we would then hope is that the model, if it predicts well, basically the dark points should be above the curve, and then the gray ones, or the light colored ones, which are the controls, they should be predominantly below. And you can see that most of the colored dots are above the curve, saying that the model has been able to snoop out something from the history of those individuals to say, oh, okay, actually here, I knew that this was around tenfold elevated risk at that time. It also gets it wrong, and it's surprised. It would have said it's actually a prediction below the average, but on average, you can see for the most part, actually the dark dots are above the curve. You see interesting patterns. For example, you can see for the breast cancer, it almost becomes bimodal. Many cases where basically there's nothing, and others for which there is information. So I can dive into this, why it is. But just in the first sanity, yes, it reproduces age incidence patterns, also sex patterns, and most of the predictions for the cases are above the age trend. That's good. Now let's evaluate this quantitatively. Because of the changing age patterns, of course, you have to do it because you don't in individual age brackets. Otherwise, you would just see the underlying age incidence trends. So these are calibration curves on the logarithmic scales, the modeled rate versus then the realized one, broken down into different 5-year age bins, each to try to account for the age effects. And you can see that across 3 orders of magnitude, actually, this is a pretty good calibration here. Sometimes it can be a little off, but on average, across the 4 selected outcomes, it is pretty good. There is some fluctuation, often because especially in the younger age groups, there are few events, but overall, it seemed to have learned really well what the rates were in the data and how to make predictions, which are then actually realized in quantitative sense. If I have enough time, I will get back to also many of the confounding factors that lead to some of those predictions, but it shows that as a modeling framework, it appears to be very well suited. One has to be very, very cautious about what the data actually contains and whether there are biases in the data. But this type of model really can make accurate predictions and not fantasize. Yeah. And those 8 outcomes are only 8 out of more than 1,200. So if you look at those age stratified AUCs, we can see basically we can predict, or the model predicts almost any disease across the different ICD chapters. In orange, for example, are the cancers. It does so with an average AUC just lower than around 0.8 in this age stratified fashion. There are some cases where it gets wrong, and this chart shows you then what the AUC for each diagnosis, which is a dot colored by the chapter, is, and you can see the ones it is struggling with, or where we are struggling with in evaluating the predictions, are effectively the rare diseases, because this is the number of occurrences in the UK Biobank training data, which was 4/5 of the data. And if it was observed less than, say, 100 times, meaning we have 20 data points for evaluation, then sometimes just the AUCs start to fluctuate between the critical value of 0.5. So the model really learns to piece together information from the data which it can then utilize to reproduce the incidence patterns from the UK Biobank very well. It does so, I would say, as good as other more bespoke models for selected outcomes. For example, for death, there are a range of established scores such as Charlson or Elixhauser. We also compared it to other single endpoint transformer models, which use a similar framework. So I would believe there is probably then also an added value of it, not only looking at the improvement, say, between another to this other machine learning model trained on the same data, suggests to me that learning from more than one outcome helps improve also at times. So overall, this is very encouraging that it does learn well and effectively from the data, and it does not do worse than individual models, even though you can also arrive at a similar accuracy by something which is simpler, obviously, but then only for a single task. And here we have effectively like a Swiss Army knife that does things all together. And also crucially, now we do the reverse translation from UK to Denmark. Also, we found that basically the predictive performance slightly diminished, but overall very well preserved, similar to what we've seen for the cancer models trained in Denmark and applied in the UK. So the structures seem to be largely similar between the two national individual systems. Okay, I have around 5 minutes left, so I'll perhaps skip one or two things. Perhaps one unique feature about the model is that it's not only making instantaneous risk predictions, so it's not like 1,000 risk models glued into one, but it can also simulate future trajectories, right? Because you can sample from this model. It says, okay, at a given point in time, this is the rate of all of the 1,000 possible outcomes. Sample one step. It's simple, just draw from, and then there's exponential distributions. Inputting it into the model again, taking another draw. This is exactly how ChatGPT builds sentences on our DeepSeek, right? But you can do the same for those health outcomes and then simulate trajectories. And what we've decided to evaluate is take basically the available information to the age of 60, where you already have, or the participants had some history recorded, simulate conditional on their history, and then compare it to the actual observed outcomes. So if you then just very crudely evaluate for each individual which diseases were predicted and which were observed, one would already expect to get around 1 out of 8 diagnoses correctly just by knowing the age incidences, right? So actually back pain or all the ailments you typically have. What the model adds to that is plus around 1 out of 20 diagnoses on top, also overall 1 out of 6 diagnoses. So these are then dependent on the specific history that each individual had. And you can see also that in the first year after we started evaluating, the margin is largest. But then after around 20 years, it is close back to the baseline, meaning that many of those events actually were not predictable over such a long period, which is also some solace because it shows that we are not actively slaves to our own history for eternally long periods. Okay, maybe I skip through this. The model also reveals interesting or provides insights into the comorbidity patterns. One challenge with these complex models, they're difficult to evaluate. Unlike, say, the Cox models I showed in the first part, they have one coefficient that models the hazard ratio. If you have this diagnosis, things go up by X fold, right? And there's no equivalent in the model that there would be a single coefficient, but you can construct a similar value by effectively evaluating the model's predictions of the same data with and without a certain input. And say, taking a case that has a diagnosis and then taking it out of the data, which factor does the model's prediction change, gives you effectively the equivalent of a hazard ratio. But you have to do this across many predictions because there are also effectively many interaction terms already in the model. But what we've shown here is the average, so kind of the linear predictor equivalent. And then cross-tabulating it across, this is the predictor by which factor it changes for predictions based on then the x-axis. And what is interesting is you see already a bit of the grouping structures within the chapters. So any diagnosis from the same chapter appears to raise also the rate of than any other diagnosis from the same chapter, because they are related diseases, effectively comorbidity clusters. It's quite pronounced for mental disorders, for example, but also for other groups. And this is for the time frame of 1 year. And you can see also this is attenuated after 10 years, even though some persist. For example, for mental disorders, you see a very sticky comorbidity pattern, whereas for others it is attenuated and then goes back to the age and sex baseline. So those the model actively forgets, and others it does not. And if you quantify it, actually using also the standard univariate method, you get qualitatively very similar results, essentially just by calculating a non-parametric hazard function and then divide them by each other. And now in the last 2 minutes, just mentioning also biases, because that is something that we really then learn, and so very clearly through the model. This framework is extremely accurate in reproducing what was in the data, but it also reproduces all the distortions which are in the data. And that is, I think, for developing these things to maturity and for applications, it is really crucial to be aware of it. A very obvious thing in the UK Biobank is immortality bias, because individuals were recruited as being living and in the age of 40 to 60, and you can see that the crude incidence or crude mortality in the UK Biobank in blue, and what Delphi estimates, it's a bit offset because the ways we calculated it is different, but you can see basically it has learned from UK Biobank you cannot die when you're younger than 40. And of course, the own estimate is very different. And this also has ripple effects, because it means that diseases which have a high association with mortality will be depleted here. It can also lead to then, and there may be then also be a certain displacement effect occurring later on. So this is really one distortion. There can also be a distortion if there are certain events or information that is recorded at around the time of recruitment. For example, many of the lifestyle questionnaires then effectively represent a certain feature at the time of recruitment. And since the model learns, well, as soon as you started in UK Biobank, you can die. Any information that also coincides temporarily with this may be used to explain this jump. And our evaluation has shown that. So this is something that one needs to be very cautious about. And another thing we realized, and that's the last slide, is also we realized, but when evaluating the model's prediction, that the actual source underlying the disease data from UK Biobank comes from 3 or 4 different sources. Some come from NHS hospital records, others are self-reported, and then there are also primary care records for another fraction. So this is roughly a breakdown for these will be 1,000 different diseases, and that then shows which source they're coming from. So one sees that basically there is a preference for where a disease record comes from. And this chart shows that then the combination of individuals who had information from the sources also varies. So there are some individuals, few, which have all the sources available, and there are many more who only have one. But that means, together with the disease specificity for a given source, that if you have a source available, also there will be a distinct diagnosis that you can find for this group. And that is something that the model also learns. So if we are splitting the individuals, the same representation. Now, just showing diseases which predominantly come from hospital or predominantly from primary care, you can see that they form a big cluster here. So any disease, say, just a runny nose, and this from primary care will also then predict more common disease. And that's probably just a source of similar from hospital records. And we've quantitatively evaluated. The more specific, say, the disease is to hospital, so the fraction of occurrences coming from hospital, the greater will be the predicted influence of any other diagnosis from the same, in this case, hospital source. So it can go up to tenfold. So as soon as this is available, then also the predicted rate goes up. There may be an element of truth to it, because of course, truly more severe disease will be registered, will be recorded in a hospital. So there should be some correlation, but we are pretty sure that it is exacerbated here due to the differential availability, and also something one needs to be cautious. And that can also explain some of the effects. Probably not all, but some. Good. So already past the hour. Apologies for talking so long. I hope I did not bore you too much. So in the first part, we show basically how to put Cox proportional hazards models on steroids by repurposing some of the machine learning frameworks, which then allow us to use them on really large data set. And then showed you how we can develop Delphi, continuous time GPT model that is generative and very well suited for modeling disease and health progression. And specifically our trained model, which we call Delphi 2M, because there's 2 million parameters on UK Biobank, show that how you can use that to model basically the entire ICD spectrum using UK Biobank data, sample health trajectories for long-term predictions, but also provide insights into comorbidity clusters, the temporal cohesion. It works across UK and Danish healthcare systems, but also reveals quite a lot of this actually data biases in the UK Biobank, which one needs to be very mindful about when one develops such models for specific, possibly clinical purposes. Many people contributed to this. So student Artem Schmuck of my group was a really lovely collaboration with my former colleagues from you and Bernie's group at EMBL-EBI and our collaborators in Denmark. And I'm really grateful for the discussion we had already. Thank you for your attention. I'm happy to answer any other questions.
Oh, brilliant, thanks. We'll take questions in the room first, but I'll go and play around with that machine to see the questions online. So, Dan.
How would you go about putting in constant covariate effects, for example, something to do with a genome?
I think it would in fact be quite easy. You would probably present this as an input at birth, similar to how we already presented sex to the model. And I think one of the opportunities here could be that effectively a model can, or the model, given that it's flexible enough and how it can then build the temporal dependencies to also highlight at which periods of life, say, a genetic effect is relevant. And also this already, while recognizing the temporal sequence of other associated diseases. So I'm quite excited. I think this could really shed new light on genetic associations. For example, does the polygenic risk score predict effectively a prodrome leading to a disease? For me, one example is, again, wearing my cancer hat, is some of the contributing factors to a polygenic risk score for lung cancer is effectively nicotine receptor. So it predicts, in fact, the likelihood of being addicted to tobacco smoking, rather than the risk of the actual disease. And I think through at least the temporal delineation that these models can do, it could be quite insightful to evaluate also these effects.
So we had one question online related to that, was from Amy, who said, have you used genetic data in the prediction?
We haven't done this in
Yeah.
depth yet. We explored a little bit, essentially just taking polygenic risk scores and putting those into the model alongside. So as a proof of concept it worked, but we don't really have a deeper insight yet how much predictive value it would add. It's certainly an analysis that would be worth carrying out.
And Michelle, you.
I was thinking, how easy is it to like sample counterfactuals from the model? You know, sample millions of counterfactuals, change one parameter, sample versus specific controls. Is it quick to sample from?
Yes, it is. So for a given individual, I mean, can even give you a demo on my laptop if you're interested in your personal predictions. That works very well, and I think they could be a real utility. For example, in phase 4 clinical trials, where actually then already a treatment is actually the standard of care. So you lack the counterfactuals, and then a model that is trained up to the point of the introduction of the drug can then be used to essentially simulate what would be expected without it.
Simply to sample local average treatment effects conditional on life course history for individuals.
Yes, if the data permits so, possibly from a clinical trial. Yes, I'm a skeptical because a naive approach into this could also be now taking all prescription data, which is also available in UK Biobank, and have a model that then also factually reveals the effect of this. But I think the reality is it's much more complicated because it does not disentangle the conditions and the reason why certain things were predicted. So what we're probably seeing is that people are have more predictions, more prescriptions of actually fare worse because they had underlying health, but that's of course not really quantifying the effect of the intervention. That's something that one needs to.
There's no prescription data yet anymore.
We don't have that, but colleagues in Finland started doing so. They can say, they told us that it improves its predictive accuracy, but probably for the wrong reasons. Right?
So we've got some more online. Louise asks, have you assessed if the generated simulated data is still sensitive or could be made publicly available?
It's a great question. For all we know, we need to be very cautious, right? Of course, you don't want the model effect just to copy the data as it is, because then it could reveal sensitive information, but also certainly then it would also forfeit in a way the principles of how UK Biobank data is being used. When we evaluated it, our impressions, well, there is certainly no further clustering of diagnosis beyond effectively the mutual dependencies between disease tokens it estimates. So in that sense, it is a truly new generated data point, but I guess if one simulates a million outputs, you can't guarantee that one of them is effectively a copy for a reason we would not expect. So it's a bit like, how can you really rule out that it does not reveal something? It should not, and from we measured it does not, but you should never say never.
And Peter Flack asks, very interesting work. Do you have a sense how much the added components in GPT buy you in terms of predictive power?
So when we compared it to our Cox models, for example, we find that they are roughly on par, perhaps a few percentage points better through the GPT model. But one thing, if you look at the number of parameters, so we fit our Cox model across the entire disease spectrum, it's 1,000 linear predictors times 1,000 different outcomes is in fact then a family of models which has 1 million parameters.
Yeah.
Delphi 2M has 2 million parameters, so it does not have an excessive amount of extra dimensionality here. It just uses them in a different, perhaps more opaque or more effective way, depending on how you look at it.
And then Paul says, I'm gonna have to get rid of, I'm gonna have to work out some technology here, shit. Yeah, Paul asks, can you comment on the limits of the P or token input of this approach, given the N of training sets, i.e. UK Biobank is largely static?
I'm not sure if I understand it exactly correct. I think we did dilution studies using just a fraction of UK Biobank's data, and that showed basically that the model has not stopped learning yet. So if UK Biobank was 10 times the size, it would probably still learn additional associations and biases. But it does not appear to be saturated.
Okay. And Hugh asks, great talk, thank you. Have you checked what the model would predict for your personal history, and do you envision this being something individuals would use?
Of course I have. Unknown 42-year-old.
Yeah.
It also, the first thing was it made us aware of the immortality bias, because it predicted that I would just die when I was 66. Which then made me realize, okay, this is only because I was basically given my behavioral input already at an earlier time than it would be recorded in the UK Biobank. But I mentioned that basically whatever is then placed at the time of the registration is confounded with a jump in mortality. I would say, well, at this stage, it is a successful proof of concept, and it shows the power of the models. But also, given the limitation we're seeing that stem comes from the available data, and when one needs to be very cautious and evaluate what would be the best possible use case and what needs to be done, for example, if that should become a true risk model, say, for stratifying individuals into cancer screening trials, or maybe we should leave, for example, statins to lower the risk of cardiovascular. This still requires much more further evaluation.
So I mean, when you actually compare to the areas, the areas under the curve with, coronary disease, Q risk to ever so slightly better, but presumably you could. What happens if you combine the two? What happens if you say, well, we've got your models data and you've got Q risk?
Yeah, I think then we could just quite simply just think about like a linear combination of the two, and I would be quite confident that this would then be more precise. There's of course also, especially when it comes to treatment decisions, because there's a tension between, do you want to have the best possible model, or do you want to have something which is simple and therefore interpretable? Because when it's a life-changing decision, right, then of course people would want to know, just to say there's a black box that tells us. So there's also an important, I think, ethical component to it, and it might differ between individuals also what they would accept in order to be the basis of their care. So I think this is a big discussion that one needs to have now, as we see the opportunities coming from such models, and for effectively healthcare, and how we want to use them.
I mean, maybe rather it might be less contentious thinking it was being used for identifying thresholds for screening, for example. Well, and that would be less.
Yeah, or I think a very immediate use case could also not be for effectively modeling individuals, but more for healthcare planning, because effectively it's a bit like having a simulation with a granularity of 1, right? So it can therefore then also make predictions for groups of individuals. Now, how many diagnoses of a certain kind do we expect, say, for a certain local demographic? So do we need to build a new hospital, or we have a hospital? Should we expand the cancer ward or the cardiovascular ward? Because there are certain trends and morbidity patterns which are already on the horizon, which are not as simple as effectively multiplying the current incidence by then the new age distribution expected in 10 years. For example, I've read that there are many more amputations being conducted in hospitals these days compared to 10 years ago because of the rising incidence of diabetes. Right?
Yeah.
And these are, of course, things that are already visible now, and we need to extrapolate those trends rather than just taking the current status and only update the number of individuals or the age distribution. And I think the model could also lend itself very well to these purposes.
That's brilliant. So it's clearly a sort of start of something that's not going to go away,
Yeah.
going to get bigger. So that was fantastic talk. So Moritz is staying around, is around all afternoon, and if you if you'd like to have a chat, then Marie, who's in the office next door, will be keeping a